Thank you, Andre. Good morning, ladies and gentlemen. Let me start by saying that it is an honor for me to raise the stage after a VIP in the true sense in current clinical and anesthetic pharmacology. It is also a pleasure for me to notice that NAVAT is one of the few remaining meetings that puts pharmacology on the program. And that is why I named my lecture, sadly, The Obituary of Synergy. These are my conflicts of interest. The word synergy comes from the Greek. That's the combining of two Greek words. And in the past it was mainly used to talk about a collaboration between human and divine powers. Only the last few centuries, synergy was used in other meanings, like, for example, economy or medicine. In medicine, when we talk about synergy, actually we talk about drug interactions that are really interesting for us, because synergy allows us to optimize efficacy and/or safety, and at the same time we can reduce the dose of the individual drug. One of the first reports of synergy in anesthesia is from the 1930s, where Sievers noted that if you give dogs morphine, then you need less cyclopropaine to anesthese them. Although the word synergy was not formally used in that article, later on there's a lot of articles published, and they state, rightfully I believe, that drug interactions are the basis of anesthetic practice. I fully agree to that. In my opinion, there's two problems. First problem we already mentioned: the articles are rather complex. The second problem is that from the articles it is not possible to calculate an individual dose for your patient. That is why visual drug displays were invented. So this is the cover of Anesthesia and Analgesia in 2010, and on the left you see GE Navigator, and on the right you have a Draeger Smart Pilot View. In 2010, Anesthesia and Analgesia devoted a whole section to visual drug displays. However, already in the editorial, they mentioned themselves that most subscribers will never read these articles. A few years later, I climbed the stage of NAVAT for the very first time, and I had to agree that nobody cares about visual drug displays. Since then, GE Navigator is not on the market anymore, as far as I know. And as for the Smart Pilot View, we have it in our own hospital, but it is rarely used. So I asked myself, are we really not interested in proper anesthetic drug dosing? Only this month, this article appeared in Anesthesiology, and there they say that we still use blood pressure to titrate our hypnotic drugs, our inhaled anesthetics. So that is why we can speak of an obituary. But nevertheless, I think adequate drug dosing, including thinking about synergy, is very necessary. First of all, there's an economical reason. If you don't give drugs that are not needed, then of course you save money. It's a logical thing that is beneficial for your patient, because if you give an overdose, they will become hemodynamically unstable, and then again you need recovery drugs. That's also a cost, and you may increase their recovery times. It's not good for the patient, it's not good for the hospital, it also costs money. And last but not least, giving the right dose is a matter of sustainability. In this recent article about sustainable drug use, they propose an 8-step efficiency model, and there you see step 5, and it's called alternative dosing strategies. And there they mention decrease the dose based on PK/PD data. For me, it's not alternative dosing, it's just adequate dosing. Because if you look at articles about synergy, then you see that only a very low dose of opioids, like here, effect site concentration remifentanil of 1.36 can reduce the CE50 of sevoflurane or propofol by 50%. That is not a small reduction, that is really significant. So, now that I convinced you, how are we going to do this? We can use visual drug displays. The one that is still on the market is Smart Pilot View from Draeger. Of course, you need a Draeger anesthesia machine to connect. So, that is one thing. If you don't have a Draeger anesthesia machine, there are still anesthesia simulators, like the one that I find very useful is from Brigham. And this one is free, available on the internet. These displays allow you to calculate a predicted dose for your patient. Of course, there is patient variability, and I think you always have to control whether the dose is adequate or whether your patient is more or less sensitive. In my opinion, I don't think you can really measure synergy, but at least you can measure if the hypnotic effect is adequate, is too much, is not enough. Also, if you reduce your hypnotic dose, you still want to stay on the safe side, so to prevent awareness, and in response to the article in anesthesiology, then we can move over to only anesthetizing the brain. So, I conclude, and I fully agree with these authors. Knowledge of pharmacokinetic and pharmacodynamic drug interactions in anesthesia does contribute to the optimization of anesthetic drug administration. Advisory screens and computer-based training tools can teach physicians and help them to apply this knowledge in clinical anesthetic practice. Thank you.